Hello, and welcome to today's event, The Health Effects of Climate Change. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so happy to have you with us today. Today's event occurs in conjunction with the release of the December 2020 issue of Health Affairs. It came out yesterday, and it's devoted entirely to the topic of the relationship between climate and health. I'm particularly proud of this issue because it's our first ever full theme issue devoted to this topic. Now, some might say, why so long in coming? And the answer is it takes a tremendous amount of work to put together an issue like this. I'm appreciative of the financial support of the Robert Wood Johnson Foundation and the Kresge Foundation. And as you'll hear from later, also our theme issue advisor, Dr. Kristie Ebi. Now, there's so much we can say about this topic, but I'm going to keep my introductory comments quite brief. We have a growing body of knowledge about the complex and multidimensional relationship between the climate and health. Partially, we observe on a daily or annual basis severe weather events, not just hurricanes, but also heat and drought, which affect our livelihood in many ways. We've experienced a terrible fire season this year, directly tied to climate change with significant effects on people's health. We're looking globally at changes in disease vectors and food production possibilities and opportunities in shortage and water shortages. We're seeing migration associated with a changing climate. The list truly does go on. It's really quite concerning. And this is our effort to add to the conversation. And I'm very pleased to be able to have Health Affairs play our part in this. Now, as those of you who've been with us for some time know, we typically would have a release event in Washington, D.C., and we would hear from all of our authors. In today's environment where things are online and attention spans are a little bit shorter, we can't get through all of the material. So I would encourage you to not just join us today, but to look at the issue itself, where you'll find papers that explore in more depth the multiple effects of climate on health, that look at the health sector's contribution to climate change and waste and pollution, that look at different dimensions of how people are adapting to a changing climate, and of course, looking at policy solutions and interventions designed to address this problem. Now, we're not a climate journal, so we didn't go deep into addressing climate change per se. But one of the many striking findings in this issue is the large footprint of the healthcare sector. We are, after all, a sixth of the economy in the United States, and the health sector is its own major generator of waste. And so even without being a climate scientist, if you work in healthcare, there is a role in not just responding to and adapting, but also preventing the emissions that lead to climate change. We always get asked, will the slides be available? And the answer is posted on our website on the event page. You will be able to get the slides after the event. We do encourage you to submit questions, and I'll say this again, during the event, just below the screen where you're watching, you'll see a place to do that. No need to wait to submit your questions. We'll queue them up so that when we get to that portion of the agenda, we have time to run through them. With that brief introduction, I'm really pleased to be able to ask representatives of the two funding organizations to make some brief comments to kick us off. I'm going to turn first to Alonzo Plough, the Chief Science Officer and Vice President of Research, Evaluation, Learning at the Robert Wood Johnson Foundation. He came to the foundation from the Los Angeles County Department of Public Health, where, among others, he was responsible for as the Director of Emergency Preparedness and Response, particularly appropriate to the topic today. We've worked with Alonzo on a range of initiatives, including, of course, the Foundation's Culture of Health. Alonzo, love to hear some opening remarks from you.
Great. Well, thank you, Alan, and good afternoon to everyone. And thank you for the opportunity to help set the stage for this conversation and share why the Robert Wood Johnson Foundation co-funded this critical issue. Robert Johnson Foundation is the largest foundation focused on health of people living in the United States. But a few people have asked me why we're funding work related to climate change. But I think Alan's remarks on this issue of health affairs and the decades of evidence it builds on explains why. Climate change is a public health crisis and one that will get much worse without action. Fortunately, we're seeing action on the ground, and we're working with leaders and communities across the nation to identify, highlight, and learn from smart, effective approaches and solutions that improve health, advance health equity, and work to address climate change. We all know that our environments, our neighborhood environments, our schools, our homes, all shape our health. The challenge is that climate change is changing those environments in dangerous and unhealthy ways. It's making the air we breathe less healthy. It's worsening the heat waves, droughts, floods, and wildfires we experience. And it's changing the ecology of how diseases are spread by insects, water, and food. This is why we are interested in finding and supporting community-driven solutions that can help us respond. Each community, each region faces different threats and has insights and assets to draw in to respond. As we approach this work, we do it with a focus on equity, as this issue highlights why no one escapes the threats to our health that come from climate change. We know that they're not felt equally by all. The impacts of climate change are uneven and unfair. The greatest burden is on those who have the least ability to protect themselves. Older adults and children, people with fewer financial resources, and many people of color who are at greater risk because of systemic racism and historic and continued disinvestment in these communities. The good news is that we can address the triple challenge of poorer health, a rapidly changing environment, and deeply rooted health inequities. Climate solutions are ultimately health solutions, and solutions to create opportunities for healthier lives and reduce inequities can be good for the climate. We respond to many challenges at once. This issue of health affairs can inform how we understand and respond to climate change and its impact on health. It offers insights into possible solutions from how Indigenous communities are responding to climate impacts and working to prevent further changes to ways school meals can both shape health and reduce contributions to climate change. So here's the simple truth. We all want to live in communities that make it easier, not harder, to live our healthiest life. We want that for ourselves, our families, our neighbors, and the generations that follow. Climate change threatens all of that. We will all experience poor health the longer we wait to act, and we will deepen the health inequities. I hope this issue can help build the momentum around responding to these issues and supporting those already doing this work. Thank you.
Thank you so much, Alonzo, and for your continued work with us on this and many other issues. It's now my pleasure to introduce David Fukuzawa, who we've also worked with for many years. He's senior advisor to the president of the Kristie Foundation with more than 20 years of experience in philanthropy. And he was behind our first ever issue on environmental health more than almost a decade ago. David, the floor is yours.
Thank you, Alan. It's always a pleasure to share the platform with you and with my friend Alonzo. And he articulated so well the basic reasons that we got involved with this, but I want to say a few other things. So, as Alan said, my name is David Fukuzawa, and I currently serve as senior advisor to the president of the Kristie Foundation, but for over 10 years, I was managing director of the foundation's health program. Kristie is a private national foundation that is not a health foundation, but works to expand opportunities in America's cities through grant making and social investment across a range of programs, not only health, but arts and culture, education, human services, community development, and probably most importantly, the environment, which is focused on climate change. And I want to call out and acknowledge and give thanks to my colleagues from the Foundation's environment team, which also contributed to the sponsorship of this thematic issue on climate and health. Now, as Alan has said, I've had the privilege of working in a number of thematic issues and have spoken at these briefings over time. But this is likely to be my last. But I believe also that this particular issue, which is not only the first on climate and health, is an important milestone in health policy communications. And I want to direct my comments especially to members of the media in my remarks, and provide 3 reasons why you should be paying attention to this issue. First, after 4 years of federal neglect and active dismissal of climate change as a threat to national security and the well-being and health of its citizens, climate change has been elevated as a priority for the incoming Biden administration. It's listed as one of the 4 major ones, in addition to racial justice, the response to COVID, and economic security. Second, this particular issue is important because it establishes climate change as a major health policy, not just as a climate or fossil fuel policy, and not as a peripheral one in health, but one central and fundamental to the nation's health. The health frame is further critical because it emphasizes so deeply the existential and immediate threat of climate change, not as a geographical or temporally distant one, in other words, not the Arctics and not 50 years from now, but now. It's affecting us now. And the third point is that it is therefore critically important to build out and expand the bridges of policy and practical solutions between these fields and realms of climate science and health. And when the Kresge Health and Environment teams decided a couple of years ago to form a collaboration on climate change and health, of which this is just a piece, we encountered some obstacles. And it wasn't just simply the communication language between the 2 teams, but the lack of sort of an intermediating infrastructure between the fields of climate and health. There were very few nonprofits or organizations or even policies and structures to help us organize our grant making around this. And our search for partners included developing a partnership with the Robert Wood Johnson Foundation, and we serve as advisors on each other's initiatives in this area. But when we started, we could not find the kind of critical partners and policies in which to sort of build out a full grant making program. So we had to sort of forge our own way. And we believe that this issue is an important building block in trying to create part of that infrastructure, especially around policy. So I just want to point that out, and I would only echo what Alonzo said around equity, that the reason it becomes so important now is because of the deep ties of this issue, not just to health, but as a threat multiplier to all the disparities and inequities that exist, especially for communities that have been marginalized and disinvested in for decades, if not centuries. So with that, again, I want to thank you and congratulate the staff of Health Affairs for putting out what I think is going to be an important contribution to the field.
Thank you so much, David. And I want to say it's hard to hear you say you think this is your last, but we knew this was coming. But equally important, I really appreciate the reflection on the institutional challenges of making an effort in an emerging area that has no natural home. And we certainly hope that this is part of finding a home for this topic in the broader healthcare sector, which after all, as I noted at the outset, is a contributor, but also just an important part of the problem and the solution to the problem. So very grateful for your work with us over so many years. We're now going to move into presentations and a discussion. We have quite a few presentations. We'll keep them on the shorter side, but it's really important, I think, for you to have a sense of the breadth of the content in the journal. And we do have plenty of time at the end for a discussion. I'd remind you again that you can put I'm already starting to get some, so you can put your questions in at any time. The earlier, the better. The slides and a recording of this event will appear on this event page afterward. You're going to hear from Kristie Ebi, Professor of Environmental and Occupational Health and of Global Health at the University of Washington. As I noted, she was the advisor for this issue. Jodi Sherman, Associate Professor of Anesthesiology at the Yale School of Medicine, Associate Professor of Epidemiology and Environmental Health Sciences at the Yale School of Public Health and founding director of the Program on Healthcare Environmental Sustainability of the Yale Center for Climate Change and Health. The first author on her paper is Matthew Eckelman, Associate Professor of Civil and Environmental Engineering at Northeastern University. He'll be available for the question period. You'll hear from Mary Kathryn Poole, a PhD student in the Department of Nutrition at the Harvard T.H. Chan School of Public Health. Paul Schramm, Climate Science Team Lead in the Climate and Health Program at the Centers for Disease Control and Prevention. You'll hear from Shasta Gaughen, Cultural Anthropologist and Director of the Pala Environmental Department at the Pala Band of Mission Indians. You'll hear from Jim Schultz, Director of the Center for Disaster and Extreme Event Preparedness at the University of Miami School of Medicine, and Nadia Holder-Hamilton, a physician in the Department of Public Health at the Ministry of Health of Nassau, the Bahamas. I promise I'll give you names before each person begins, but I did want to make sure you knew who our presenters were today. So without further ado, our advisor and the author of our overview paper, Kristie Ebi, the floor is yours.
Thank you very much, Alan, and I want to join others in really thanking you for the vision to take this on and the leadership to make it happen. And I also want to thank very much the funders to make sure that we could bring this issue out. As Alan noted, there is a rich amount of information in this issue, and I'm going to give a one-slide, very brief overview of the health risks of a changing climate. So if I could have that slide up, please. Thank you. I want to start with a couple of background comments. The first is, as David noted, climate change is a stress multiplier. So it does put pressure on situations that are already causing disparities, that are already causing adverse health outcomes. And when we think about the health risks of a changing climate, we need to think both about what I'm mostly going to talk about now, population health. But you're going to hear equally important from people who are working on the side of our health systems, that the consequences of a changing climate in terms of changes in the mean and variability of temperature, precipitation, stronger storms, more frequent extreme events, changes in the geographic range of a variety of vector-borne diseases. The list is very long. And all of that has consequences for our own individual health, our families, our friends, our colleagues, but also has consequences for how many people show up who need health care. And it also impacts the ability to access that health care. So this is an overall framing when we think about the health consequences of a changing climate. And it illustrates very strongly that we're talking not just about climate variability and change, but we're talking about the interactions between the greenhouse gas emissions that are driving climate change with a variety of socioeconomic drivers within the context of large global environmental changes. It's not just the climate that's changing. Land use change, biodiversity loss, water stress are other drivers that are challenging for us as individuals, for our communities, and for our health systems. And we need to keep in perspective these other drivers, that we've got large demographic changes going on within the United States, around the world, urbanization, the extent to which there are investments in science and technology. And that can change with political leadership quite strongly, if we've seen over the last couple administrations here in the United States. And as everyone has pointed out, this all interacts with inequities. When we think specifically about climate change, 80% of emissions come from just 20 countries. So we have to look at what those countries are doing in terms of trying to reduce their emissions, but also when you look within countries, whether or not they're high, low, or medium emitters. It's the people who are emitting the least, who have the least access to resources, who are the most affected by a changing climate. The socioeconomic drivers, global environmental change, climate change is one of those, interact with vulnerability and susceptibility. You can have a flood in a place where you have no people and not have any consequences. You can have a flood in an unplanned settlement and have enormous consequences. So it's really important when we think about climate change, we take into consideration this much broader context, that we are looking at the stress that's being put across society and understanding then how climate change is affecting the burden of disease and affecting the ability of our healthcare facilities to function appropriately in particular locations at particular times. That even in high-income countries, there are populations who are particularly affected that will shift as climate continues to change. And on the bottom, I've listed some examples of health impacts and health risks. This is not a complete list. That when you look at all the possible health outcomes that could be affected by changes in our weather patterns, it's just about everything that a department or Ministry of Health has to cope with. It's a cross-cutting issue within our health systems and needs to be addressed at that level of really understanding what needs to be done on everything from undernutrition to vector-borne diseases to mental health to violence, conflict, and migration. And the good news is that because all of the health risks of a changing climate are current problems, that means we do have policies and programs. They have not yet been designed to take climate change explicitly into account, but they can do so. And I assume we're going to hear more from Paul about that in his presentation, because CDC has done a lot of work in the United States on this issue. And so we have a lot that we can build on. We have a long way that we need to go. We're some way down the road, and we need a lot more investment to be able to really achieve the potential of framing the climate change issue from the health perspective so that we can protect and promote population health and well-being, even as our climate continues to change, and even as the health system then plays its role in ensuring that we reduce our greenhouse gas emissions. And with that, Alan, I'll turn it back to you. Thank you very much. I want to really thank you again for all you've done on this, and I look forward to the other presentations and to all the questions and answers. Thank you.
Thank you so much, and for that incredibly succinct presentation of so much content. We'll turn now to Jodi Sherman. Jodi, the floor is yours.
Thanks, Alan. Can I have the first slide, please? On behalf of my co-authors, I'll be presenting our article, Healthcare Pollution and Public Health Damages in the United States, an update. Next slide, please. As a disclosure, I'd like to point out that the Yale Program on Healthcare Environmental Sustainability has received a non-designated gift from the Association of Medical Device Reprocessors, which have had no say in this study. Next slide, please. So in this article, we do three things. Firstly, we update the national level U.S. health sector emissions covering years 2010 to 2018, and we classify them into the greenhouse gas protocol scopes of 1, 2, and 3, and estimate healthcare pollution damages to public health. We also estimate state-level emissions and examine their association with energy systems, as well as healthcare quality and access metrics. And finally, we suggest healthcare organization emissions reporting frameworks and accountability mandates. Next slide, please. So as Alan said, the U.S. healthcare sector is quite large, accounting for 1/6 of our national economy. This has significant emissions implications. Understanding how much and where these emissions occur are essential for policymakers to drive mitigation efforts. It's not feasible to count all the materials and energy used for each patient and each device and each drug, but there are methods, both used previously and ongoing work, that use national economic input-output models. You see a list of citations below that use this method, that translate healthcare monetary expenditures into greenhouse gas emissions. Next slide, please. So how do we count emissions that occur both directly and indirectly from the healthcare activities? Well, firstly, we start with national healthcare expenditures. These are compiled through the Centers for Medicare and Medicaid Services. This is then plugged into input-output tables that are compiled by the Bureau of Economic Analysis. This tells us how much expenditure in the healthcare sector induces economic activity in all the other hundreds of other economic sectors, including energy, agriculture, and chemicals as some of the big ones. Each activity causes some emissions upstream and downstream, and understanding how they are interlinked and accounting for the emissions throughout the network is required. These emissions or this economic activity is then linked to emissions provided by the EPA. Next slide, please. So these are the national level results for 2010 to 2018 depicted here. Firstly, we notice a decline until about year 2012, and then a steady increase in overall emissions. We're now at 8% of total national greenhouse gas emissions stemming from U.S. healthcare. That's worth emphasizing. Also, per capita healthcare emissions are the highest in the world. And of note here, scope 3 emissions, which are the supply chain, account for about 4/5 of total emissions versus 20% from the other two scopes, scope 1 being direct facility release emissions and scope 2 being purchase electricity, both of which historically are the focus of sustainability efforts, and where we have a lot of work to do is how we account for scope 3 emissions and try and mitigate their impacts. Next slide, please. So again, 4/5 of emissions stem from the supply chain, and in particular from food, pharmaceuticals and chemicals, and medical devices and supplies. These are the biggest categories. And there are two broad ways of how to address these, including focusing on efforts to reduce demand through preventive medicine and avoiding unnecessary care, and reducing waste through innovations in administration and clinical practice. The other big way is to improve the environmental performance of the materials that we use. And this occurs at the level of manufacturers and is very much dictated by regulations. Next slide, please. If we delve into state level results, we notice that there are some differences between states. These reflect how much each state spends on healthcare per capita, how that money is spent, and how each state produces electricity. Some states have very high emissions per capita, for example, North Dakota, West Virginia, DC. We also look for associations between healthcare emissions and healthcare performance. This is noted in the bottom right-hand slide. These were not well correlated, however, meaning that there's opportunity to reduce emissions without sacrificing healthcare quality. Next slide, please. We further estimated public health damages from U.S. healthcare sector pollution, which resulted in an estimated loss of 388,000 disability-adjusted life years in 2018 alone. This is similar in magnitude to the 44,000 to 88,000 preventable deaths due to medical errors first reported by the Institute of Medicine in 2000, their famous To Err Is Human report that sparked the patient safety movement. These preventable deaths had an average 10 years of life lost, so that's where you see the similarities. And we would argue that pollution prevention is a new patient safety movement. Next slide, please. So importantly, this tells us about averages on the national level, but where we really need to see changes is on the local level. So activities that reduce harm from healthcare pollution should be mandatory. This should be part of what we do in patient safety. Healthcare organizations should be required to measure, report, and provide plans for reductions in alignment with science-based targets. This requires a unified systematic reporting structure that allows performance tracking at the facility level where energy and resource consumption occurs. This would enable implementation of mitigation practices that are feasible and effective at the local level. A large number of healthcare organization variables need to be taken into consideration, and comparison of environmental performance will require that facilities and clinical activities be peer matched. This could be achieved through the Centers for Medicare and Medicaid Services with their oversight using existing performance and reimbursement infrastructure. Next slide, please. On behalf of my co-authors, I say thank you very much.
Thank you so much for that presentation and for opening certainly my eyes to the incredibly profound role that the health sector plays in creating emissions, not just in trying to respond to them. We'll now turn to Mary Kathryn Poole. The Zoom screen is yours.
Thank you so much for having me here today. So I will be presenting a brief summary of our study that explored the alignment of U.S. school lunches with the Eat Lancet Healthy Reference Diet Standards for Planetary Health. Next slide, please. I'd like to first acknowledge my wonderful co-authors, Dr. Aviva Musicus and Dr. Erica Kenny, as well as the funding support received by the NIH. Next slide, please. So food systems are estimated to account for up to a third of global greenhouse gas emissions, making it an important issue for preventing climate change. So our study set out to consider how a wide-reaching program like the National School Lunch Program might play a role in helping to fight climate change. The National School Lunch Program is a very large program serving 30 million students meals on school days. And this program plays such a critical role in helping to alleviate food insecurity for kids and may provide up to half of a child's daily caloric intake. In terms of nutrition, the National School Lunch Program has made significant improvements in recent years, most notably through the Healthy Hunger Free Kids Act of 2010, which updated the program's nutrition standards, which has dramatically improved diet quality for millions of children. Considering the scope of the National School Lunch Program, its volume, and its substantial impact on market share, we wanted to consider how the National School Lunch Program could simultaneously promote nutrition and environmental health. And so to do this, we compared the makeup of an average school lunch to benchmarks for environmental health from the Eat Lancet Commission's Healthy Reference Diet. So this set of targets was developed by a global team of experts in nutrition, agriculture, and environmental health. And together they formed this unique set of dietary recommendations that promote optimal human health while staying within a safe operating system for environmental health. So as you can see in this graphic, the diet encourages a lot of plant-based foods, fruits and vegetables, whole grains, legumes, but then the diet discourages things like animal proteins, added sugars, refined grains, and saturated fats. Next slide, please. For our study methods, we leveraged USDA data from a nationally representative sample of US public schools that participate in the National School Lunch Program. So we analyzed lunch menu data from more than 1,000 schools and then calculated the average amounts of food prepared in an average school lunch across 18 distinct food categories. Then we calculated the average amounts for a lunch of equivalent calories based on the Healthy Reference Diet across those same 18 food categories. And in both cases, we estimated these amounts in grams. We then tested for differences between the lunches across the 18 food categories. Next slide, please. So here you can see the 10 categories for which the differences were largest between the average school lunch and the Healthy Reference Diet lunch. So you see that the average school lunch served more dairy, fruit, refined grains, red meat, so beef, lamb, and pork, and then starchy vegetables and tubers compared to a Healthy Reference Diet lunch. The average school lunch also served fewer whole grains, beans, lentils, and peas, dark green vegetables, peanuts and tree nuts, and other vegetables. I've highlighted the legumes, red meat, and dairy in red here just to highlight that these may be potential areas where improvements may have substantial impacts for both human and environmental health. For example, the replacement of some red meat with legumes in a person's diet is associated with a reduction in the risk of diet-related disease. But this substitution also benefits the environment since the production of red meat contributes to substantial greenhouse gas emissions. Next slide, please. So as far as the implications for our study, I want to first be sure to acknowledge that we started working on this study over a year ago, prior to the pandemic. So the school food environment has drastically changed in that time. And so by far the most important thing right now is ensuring that kids have access to food. And there are many heroic efforts being led by schools and partnering organizations right now to do this. However, in thinking about future next steps to align human and environmental health goals in the National School Lunch Program, there are several considerations for making this progress. First, any changes should build upon the major successes achieved by the Healthy Hunger Free Kids Act of 2010. However, to promote environmental health, we suggest thinking of ways to balance the types of foods offered that may be less harmful to the environment. For example, this could involve replacing some portions of red meat with more plant-based proteins. Another area to consider is milk. So milk is an absolutely important source of vitamin D and calcium for kids, but about a third of milk is wasted at lunch. So there could be ways to consider how can we have some alternative sources of calcium, or are there better ways to minimize the amount of milk waste? As far as future research opportunities, I would recommend developing sustainable diet benchmarks specifically for children. So the Healthy Reference Diet was designed for an average adult, and while we did adjust the guidance to align with the caloric needs of children, there may be guidelines that need to be tailored to specific dietary needs for kids for proper growth and development. And then other next steps to explore would be thinking about how would cost, labor, equipment, and those type of operating expenses change to make any type of changes to existing meal practices. And then finally, I think there's a great opportunity to learn from students about what their perspectives are on sustainability and school lunches. Climate change has been documented as a major concern among younger generations, so helping school lunches better align with goals for planetary health could be a really meaningful way for youth to contribute. Student engagement would also be really essential for menu planning and taste testing to ensure that meals are appealing and well received by students. So in conclusion, as the threat of climate change continues to impact our country and the world, incorporating sustainability goals into one of our largest food programs in the US is warranted and could have lasting impacts for our health and the planet. Thank you.
Great, thank you so much. We'll now hear from Paul Schramm and Shasta Gaughen talking about the Climate Ready Tribes initiatives. Paul?
Great. Thank you, everyone. I'm Paul Schramm. I am the climate science team lead with the Climate Health Program at Centers for Disease Control and Prevention in Atlanta. And I'll be talking a little bit about our Climate Health Program and the Climate Ready Tribes initiative before I turn it over to Dr. Gaughen to talk about a specific case study with the Pala Band of Mission Indians. So our program here at CDC, the Climate Health Program, was formally established in 2009. So we recently celebrated our 10th anniversary. And we work to empower communities around the country to protect human health from a changing climate. We do this through three main strategies. The first is building capacity. The second is expanding the science base and the evidence base. And the third is telling the story, which is our communication strategy. This work includes funding health departments to implement our BRACE framework that stands for Building Resilience Against Climate Effects. We began funding states and cities in 2010, and we currently directly fund 16 states and 2 cities to implement the BRACE framework. But we recognize that tribal communities were both uniquely vulnerable to climate change and also leading the way in innovative adaptation work, utilizing traditional knowledges and novel approaches. So in 2016, we partnered with the National Indian Health Board to launch the Climate Ready Tribes Initiative. And this initiative is specifically to support tribal climate adaptation work, both financially and in terms of technical assistance. To date, we funded a total of 10 tribes, which you can see on this map, on a variety of projects. And the health impacts in these tribes are really different, as you can tell by the geographic differences on this map. So they've covered issues ranging from heat-related illness to harmful algal blooms, foodborne disease, even exposure to wildfire smoke. It's really quite the breadth and scope of different projects. Our article on this special issue of Health Affairs is titled "How Indigenous Communities Are Adapting to Climate Change Insights from the Climate Ready Tribes Initiative. And it really describes the lessons learned from the initiative while highlighting two case studies, the Swinomish Indian tribal community and the Pala Band of Mission Indians. Our evaluation found that tribal climate health policies may be more effective when they're driven by tribal experts instead of being directed by states or the federal government, and that enhanced coordination and collaborative efforts will help to improve tribal climate adaptation work and facilitate the sharing of best practices. So we've already begun to do that in a number of ways, including a tribal learning cohort and a series of webinars that CDC has hosted with the National Indian Health Board. There's also a great amount of diversity between tribes as well as within individual tribes. So there's really no one-size-fits-all climate adaptation solution. But frameworks developed by the Swinomish and Pala could be tailored to the specific values and needs of individual tribes. And the Swinomish have been developed publicly available modules so that other tribes can utilize those. I'll now turn it over to my co-author, Shasta Gaughen. She's the Environmental Director for the Pala Band of Mission Indians, and she'll be discussing some specific work she's done building capacity to address climate impacts with the Pala Band of Mission Indians.
Thank you so much, Paul, and I'm really pleased to have the opportunity to speak with you all today. To start, I want to acknowledge the land that I'm speaking to you from. I am on Payom-Cowichum territory, or more commonly known as Luiseno, in my office here for the Pala Band of Mission Indians on the Pala Reservation. And I am not myself a tribal citizen, but I have worked for the tribe, and I'm an anthropologist, and I've been doing my work here for 16 years. And, Paul mentioned the article. We were part of the article as a case study, and in Pala, we use the money that we were fortunate to receive from the CDC through the National Indian Health Board's Climate Ready Tribes program to develop a framework to look at some of the emotional and mental health impacts of climate change, not just on the Pala Band, but to create a framework that could be tailored for use by tribal communities throughout the United States. So we've had 3 or 2 years worth of funding, and we're starting on a 3rd year. And with those first 2 years, part of our outreach with the tribe was to determine how some of the more commonly indicated effects of climate change, things like extreme heat or flooding, extreme weather events, of course, sea level rise, those are kind of the classic things that people think of when they hear climate change. How are those impacting the tribal communities, not just on an environmental level, but on a cultural level? So what I mean when I say that tribes have been impacted culturally by climate change is that those environmental effects end up having effects on landscapes and resources that are culturally significant. So for example, in California, many tribes rely on oak trees as a traditional food source. Nobody relies on them for day-to-day subsistence anymore, but acorns are still a really important cultural food that are gathered to be made into different foods. In Pala, it's an acorn mush called Wiwish. And those foods are part of important milestone events in the tribe's life. So whether it's a new baby being born or somebody getting married or an elder passing away, having access to acorns so that you can have Wiwish is a very important part of tribal culture. And there are similar foods, different foods, not just acorns, but other foods throughout tribal communities that are important. And those are being affected by climate change. So from a mental and emotional health standpoint, what impact does that have on a tribal member's mental health when, for whatever reason, because of a climate change impact, they can no longer gather the food that was important for those tribal special events? If you can't make acorn mush, then how does that affect your identity as a member of the tribe? How does it affect the community coming together if they're celebrating something without being able to use that traditional source of cultural pride and cultural belonging, such as the acorn mush or perhaps wild rice or famine in the Pacific Northwest, and we know that climate is impacting those things. So a lack of access to that because of climate change has definitely led to crises of identity, mental and emotional health, senses of loss and grieving. So we used the money that we got from NAHB to develop a protocol and a framework that we've applied at Paula to help people manage some of those mental and emotional health implications. And we call it, in Paula, we call it Our Hearts Are Happy. It's actually in the Kupeño language, which I don't know how to pronounce, so I'm not going to try to pronounce it. But we've made the framework that we developed for Paula available for other tribes to use and customize for their own particular social and mental health impacts, in the hopes that what we've done is going to end up being helpful to other tribal communities. And we talked about this as part of the case study in the article, and we are continuing to use it. And I want to say, ironically and sadly, we've been able to use it somewhat in response to the COVID crisis as well, even though that's not explicitly linked to climate change. But there are multiple different issues that are causing emotional and mental health issues, not just in tribal communities, but throughout the world. So our hope is that we're going to be able to spread this and share it. And we do have an avenue for doing that, which is our website for the Tribal Climate Health Project. It's tribalclimatehealth.org. And I'm looking forward to entertaining questions about that during the conversation period. Thank you.
Thank you, Paul and Shasta, for that presentation. We'll now hear from James Schultz and Nadia Holder-Hamilton talking about the mental health consequences of Hurricane Dorian. James.
It is our pleasure to talk to you today about scrambling for safety in the eye of Dorian, mental health consequences of exposure to a climate-driven hurricane. September 1st, 2019, Hurricane Dorian is approaching the Abacos Islands in the northwest Bahamas. You can see the saw blade in dark blue of eye wall winds spinning at 185 miles an hour. And in the center, the eye where you can see down to the surface of the Atlantic. In just a moment, it is making landfall at the strongest wind speeds in the history of Atlantic storms. And we stopped it right here so you can actually see at the very moment where the storm is over Marsh Harbor, which was the bullseye. And this is the experience you'll hear about directly for the people who had just gone through the strongest winds and had several hours to scramble for safety inside the eye. We have a remarkable cast of authors. I'd like to introduce you to several of them who bring a multidisciplinary scientific perspective. But what is most remarkable is that 5 of our authors are physicians from the Bahamas who infuse this story with their own personal experiences at the moment of and shortly thereafter impact. Next. At Deep Center, we've been training for a number of years on disaster behavioral health and resilience for frontline professionals. And, next slide, much of the time we've been focusing on hurricanes, including our safety function action course update that came out this very year. Next. Our senior author is Dr. Sandro Galea, Dean of the School of Public Health at Boston University, who has done seminal research on the mental health effects of Hurricanes Katrina, Ike, and Sandy, and we are citing much of his work in our paper in Health Affairs. Next. We'd like to make 3 points that come from both his research and the research in the field of disaster behavioral health. And those are, first of all, number 1, in a disaster, the size of the psychological footprint greatly exceeds the size of the medical footprint. Certainly the case during Hurricane Dorian. Simply, more people are impacted psychologically than are impacted medically in a disaster such as Dorian. Next. Second point is there is a spectrum of severity. Virtually everyone who was exposed to Hurricane Dorian experienced, understandably, fear and distress, but a subset progressed to psychiatric disorders, including PTSD. What made the difference? The degree and intensity of exposure. And as we mentioned in Marsh Harbor, the entire community was impacted by the full force of the strongest winds. then had several hours inside the eye, and then the back of the storm hit them with equal force. Next, please. Third point is that psychological consequences extend far beyond the time when the hazard is operating. So while there was about a 2.5-day period, while Dorian was spinning at hurricane force across the Northwest Bahamas, it seemed interminable, but it was 15 months ago. To this day, we have major damage, resource losses, grieving for those who lost their lives, and enduring life changes. Many people have never made it back to the Abacos. Next, please. Dr. Jim Cosson is one of our key authors on our papers, and he has been remarkable as a renowned NOAA scientist. For example, front page of the New York Times last May, when he came out with a paper that looks at climate changes making hurricanes stronger. We certainly saw this with Dorian's rapid intensification. Next slide. But in addition to that, his research and that of other atmospheric scientists has shown that these storms are wetter. So with Dorian pulled a 2-story storm surge over the Abacos. And slower moving, Dorian was the quintessential example of all three of these. In fact, it came to a complete halt over Grand Bahama. Next slide. Craig Fugate also gave us the emergency management perspective. He was the FEMA administrator for 8 years. I first met him during Deep Center trainings in 2004 when Tropical Storm Bonnie, followed by Hurricanes Charlie, Francis, Ivan, and Jean crisscrossed the state of Florida while he was our state emergency director. Next slide, please. So it turns out that last year we were presenting with Dr. Sally Espinel, a psychiatrist, about climate-driven storms at American Psychiatric Association, followed by bringing our whole team together to write these 2 papers. And just as we were publishing our forecast for increasing mental health consequences from climate-driven Atlantic hurricanes, Dorian took place as an exclamation point to that forecast. Next slide, please. So we immediately started, even as the storm was continuing, to write this paper about something you've heard about from other presenters today, not only the fact that this was a stronger, wetter, slower moving trifecta of storm attributes, but also environmental injustice. This was impacting an island state that contributes virtually nil to greenhouse gas emissions. But what happened here was actually quite remarkable. It transformed our health affairs story, because it turns out that in an interview that included Dr. Krista Nadic, a Bahamian physician who had been experiencing the storm herself, she introduced me in turn to Dr. Sandeep Gaud, who was on the relief team coming 4 days after impact, who in turn introduced me to the couple, Dr. William Hamilton and Dr. Nadia Holder-Hamilton, who were on the ground in the storm at the moment of impact. And Nadia is going to take up the story at this point. Could I have the next slide, please? And this was exactly her vantage point in the eye of the storm as she was triaging patients, and she will describe what happened next.
Thank you, Jim, for a very informative start to this presentation. I am Dr. Nadia Holder-Hamilton, one of 4 physicians that survived Hurricane Dorian's wrath. Pictured on this slide is the scene of my story. The Marsh Harbor Health Center, one of 2 standing government structures during the passage of this powerful storm, that made landfall first in Marsh Harbor, Bahamas. At this time, I will give you a glimpse of my experience of hurricane conditions lasting more than 24 hours during the front eye wall, the eye, and the rear eye wall. During the front eye wall, the on-call team led by Dr. Aswood were in the clinic, while the rest of us bunkered down at the staff quarters, indicated by the red arrow. The safety of the quarters soon became compromised. With rising water and shattered windows, communication was subsequently lost. Here is the actual audio clip sent in hopes of rescue on that day. The emergency number is called. We don't know if we're going to move our stairs yet, but just in case the signal comes back in, we are still at apartment 2 on the right side, or the left side, the single room apartments. Water is coming in, rain is coming in. Things are all hitting the glass seems compromised, the roof seems compromised. We need help, please, thanks. And as hope continued to fade, my husband, Dr. Hamilton, and I made a final attempt to seek shelter. We left our damaged unit during the full force of the wind, in knee-high water and with foreign debris seemingly aiming at our heads to reach our neighbor's unit. We kicked and we screamed at her door, and after being unable to get their attention and in fear for our lives, we returned to our damaged unit, believing that with each howl of the was the beginning of a drive, filled with fear and uncertainty in the eye of Dorian. Please play video. The two stars in the adjoining image show the route we took between the staff quarters and the clinic. There were moments of calm mixed with intermittent gusts of unbelievable intensity. It was a daunting drive, but we were welcomed by the faces of our team members. Next slide, please. This moment, however, was short-lived. As I looked through the glass of the clinic's main entrance, a dump truck pulled up, and I watched in astonishment as locals cascaded over the side of the truck and into the clinic, like a panicking stampede on a Black Friday sale. Everyone was scrambling for shelter. In essence, we had created our very own public health emergency. Next slide, please. We at the Marsh Harbor Community Clinic had just become a shelter for more than 1,500 persons. This slow-moving, strong surging hurricane had left turmoil to catastrophic proportions in its wake. Next slide, please. Being on the front lines was not only riveting, but psychologically distressing in the rear eye wall. We had little sleep. It was emergency after emergency while running on pure adrenaline. Some of the physical injuries encountered are displayed on this slide. And as we bring this presentation to a close, I would want to emphasize the mental health effects seen amongst two populations. Firstly, the patient population and the healthcare worker population, with significant overlap in the acute phase. So from the patient perspective, they looked for anyone who would listen to their stories of family members being swept away and loved ones being lost as the water raged, as limbs were severed, stories of bodies floating in the water while they waded to the clinic for shelter. Parents recounted having to leave their children behind, and children recounted leaving their parents behind. The stories from the healthcare workers sounded eerily similar, with some nurses swimming in contaminated water for hours, with their children on their shoulders to save them from the floods, while others recalled the complete demolition of the structures that they once called home. So many of my colleagues lost everything, not knowing where their family members were to take care of those that they had promised to serve. For me, they exemplified service before self. Most of us experienced PTSD, and more than 15 months later, we are still recovering. Next slide, please. The community of Abaco has changed forever. The landscape remolded and reshaped in the passage of this mega climate-driven storm. However, out of the ashes, like a phoenix, I saw mental toughness and the true making of lifetime heroes who gave their community service worth the highest honor. And on behalf of my co-authors and I would like to say thank you.
Well, thank you for that presentation and such a deep insight into the reality of what climate change means. I've received a tremendous number of excellent questions. I'll keep reading them as they come in, but we may not be able to even get through the ones that we have so far. I'll start with a series of questions that have come in. We are, of course, a policy journal, so our audience is thinking, what do we do about this? And a number of questions having to do with a new administration coming in, the role of CMS, Centers for Medicare and Medicaid Services, as a payer, potentially private payers. So let's start with the question of the payment side for healthcare. What is it that could be done? What would you ask payers to do to help re-engineer the American healthcare sector and system into one that does not contribute so heavily to greenhouse emissions as well as other pollutants? I think I'll probably start with Chris, if you don't mind. Jodi, I have a feeling you may want to jump in. And of course, we'll open up to others as well.
Thank you, Alan, and thanks for that excellent question. It is really important that the healthcare facilities, particularly the larger ones who have the financial resources, commit to reducing their greenhouse gas emissions. There is a number of efforts underway in many of the larger hospitals. It would be excellent if those were replicated and speeded up so that we can really rapidly reduce how much greenhouse gas emissions come out of those facilities. And making a pledge and keeping to that pledge would be an excellent place to start. I look forward to comments from Jodi.
Thanks, Chris. Well, there are a number of organizations that are voluntarily trying to reduce emissions. As I had alluded to, mostly we see accounting happening on scope 1 and 2 emissions, meaning direct emissions from operations of the facility. Really what's lacking is accounting for scope 3 emissions, or the utilization of all the supplies that we use. And the challenge is that this is directly related to how we take care of patients. And so in order to have appropriate accountability, the best way to do this is to have accounting mandated through CMS and have it tied to clinical outcomes. We already do this in our pay for performance system through the Affordable Care Act. We're talking about now just extending that framework to require accounting for greenhouse gas emissions as a starting point. It can also be extended to water and other emissions. This is what's happening in the National Health Service in England as an example. But importantly, we have to match health system performance. This includes clinical activity, the resource consumption, the supplies, the dollars spent, and clinical outcomes. So this really ought to be mandated through CMS.
Very helpful responses. I'm going to let you all wave at me if you want to jump in. Otherwise, I'll move to the next question. We have plenty here. So let's flip to the other side of this. These last stories were really stories of inequity, of disparities, of the differential impact of on low resource communities, largely as a result of activities occurring in much higher resource communities. And of course, this has global scope, and we see it playing out domestically as well. How do we change the discussion here to align responsibility for addressing these problems with those who are most responsible for creating them, not those who are bearing the burdens who aren't responsible? What does it take to shift the debate here? Who could weigh in on this? Chris, I'll let you start off, but I hope we can also get some of the others in as well. Chris, go ahead.
I assume others have comments as well. Political will and commitment are critically important. We have stimulus packages. Hopefully one will be passed soon around COVID-19. It's a real opportunity to think about how to create the societies we want to live in over the coming decades. You think about, for example, heat-related morbidity and mortality, and how that is affected by redlining. And as we use the stimulus packages, can we really address those redlining practices that marginalize so many communities into places that are hotter? And so we have money that's going to be used over the next couple of years to try and re-stabilize our economy after the massive hit of COVID-19. And if we have the political commitment, we can really move forward in a much more sustainable and resilient fashion by being conscious about the choices we make, ensuring that they address inequities as well as the risks of a changing environment.
Shasta.
Thank you. I think I heard my name.
You did. I'm sorry. I was a little slow to the mute button.
That's okay. So just piggybacking on what Chris was saying, this is an enormous issue for tribal communities. And for generations, for centuries, we have been dealing with the effects of colonialism. And that's been an enduring legacy, not just for Indigenous communities in the United States, but throughout the world. And when it comes to mitigating and learning to deal with the effects of climate change on the environment and on health, at the most basic level, we have to acknowledge the ongoing intergenerational trauma that colonization has caused, but also the inequality that continues to be perpetuated from that broader system. And so when we have communities whose biggest day-to-day concern is whether or not they're going to be able to put food on the table, or whether in the case of Dr. Hamilton's just really gripping tale of what she endured during the hurricane, whether your house is even going to be able to stay standing in the face of a severe weather event, if that's your day-to-day concern, then it's harder to take your mind beyond that into, well, what are we going to do from the top down to manage climate change? So I would say that the investments that need to be made into just creating more equal opportunity in general and managing those most basic needs that have to do with survival, but also have to do with basic human dignity, access to healthcare, access to food, access to safe shelter, all of those things. If we manage those, then I think the climate change problem will also be well addressed, because a lot of those things are intertwined.
I want to stick with the mental health topic for a moment. Shasta, I know, and Paul, maybe from some of the other tribes you've worked with as well, there's a wellness and well-being component to adaptation. And of course, the story we heard from the Bahamas is focused very much on mental health. We have our mental health treatment system is very individually oriented, and I'm curious about the language we use here and how we describe and address the problems. These really seem like systemic problems. They seem like population health, mental health burdens, not individual. Obviously, they're experienced by individuals, but they arise from community events and socially determined events. So I just wonder, what is the thinking from an Indigenous perspective, a tribal perspective, on how to handle the mental health burden without making it a, let's solve your individual mental health response to this when so much of this must feel outside of people's control? I don't know if... Shasta, why don't you...
I can try to tackle that.
Okay, get us started, and then I'll bring in Dr. Hamilton if she...
I would just say that there's a little bit more of a community focus, and actually more than a little bit, there's a lot more of a community focus. And in the Western world, we have a tendency to focus on the individual, but Indigenous communities writ large are based on community, the idea that the survival of the individual is inextricably linked with the health of the community, and vice versa. So a little bit more of that cultural aspect of things, that as long as the community is doing well, then we can focus on individual needs, and the other way around. I think that's really where it needs to go, and not just in Indigenous communities, but in all of our communities. And I apply that to myself. I was thinking recently, I don't even really know my neighbors, and I should, because what affects them could ultimately affect me. And I think that their health should be linked with my own health. And so I think we can take that lesson from tribal communities that put more emphasis on making sure that everybody is okay. And when everybody is okay, individuals are also most likely to be okay.
Other reactions to this? James, yes, go ahead.
So in regard to the mental health aspects, and we certainly see this with Bahamas after Dorian, but we see this worldwide. Certainly mental health dimensions of climate-related disasters are really pervasive and long-term, and they certainly are population health issues. So, one of the things that would be really beneficial, certainly is happening in Bahamas now, is that the World Health Organization, or in this hemisphere, PAHO, really brings to bear, a much more population-focused approach to mental health, one that involves going out into the community, doing some case finding, but it's on a population-wide basis. So with a hurricane, there's virtually nobody who's not been impacted psychologically in a storm of that magnitude on an island where you have no option for evacuation. And so, for example, it's probably very important for us in the US to reconnect with our support for the World Health Organization and for PAHO, because in fact, they've actually put together a very comprehensive set of approaches that involve outreach, that involve screening, that involve actually stepped care models once you identify the people who are not doing as well, that also do some task shifting so that you can have community health workers or persons who are more paraprofessionals being able to extend the reach of the clinicians. So there are already really good models. We haven't implemented them quite so well in the US.
If no one else wants to jump in on this, we have a number of questions from people in the private sector who say the roles and responsibilities that have been discussed tend to center around government regulation, government policies. If you're in the private sector at this point as a purchaser or running a hospital or anywhere else, we're not waiting for the government to act, but trying to figure out what your contribution can be. What would you say to those? Who wants to volunteer? Jodi, go ahead.
Well, we do see a lot of activity happening in industry for sure. I think over 80% of large organizations now are doing some form of CSR reporting or corporate social responsibility reporting. Unfortunately, this is not, a small minority of healthcare organizations are doing such reporting. Industry is leading the way. However, even within that movement, Scope 3 emissions are largely ignored because they're the hardest to account for. So I would say that for industry to stay competitive, they should be reporting those emissions, but they should do it to the highest level possible. And that includes tracking their Scope 3 emissions or their supply chain emissions, even in the production of supplies, and also having science-based targets to reduce those emissions and reporting them. That's also going to help them stay more competitive as healthcare organizations and systems become more stringent about requiring environmentally preferable products.
Chris, go ahead.
Thank you. And it's an excellent question. There are many opportunities. When you think about, I'll go primarily with the larger companies. Their goal is to have healthy workers and healthy communities. And as COVID-19 has very dramatically illustrated, public health is underfunded. And there's many opportunities for industry to partner in a variety of different ways. There are electric utility companies that are helping to support heat wave early warning systems, for example. There's companies in parts of Africa that are helping to support malaria surveillance programs, because in fact it's cheaper for them to support the programs than it is to deal with all the workers and their families who've got malaria. And it doesn't take much for a company to look at the costs and the benefits of providing some services that are not being provided because of the underfunding of our health systems that would overall improve the health of their workers, the health of the community, and make the company more profitable, make the company a better corporate citizen.
I'm going to turn in a different direction. Mary Kathryn, I'm going to ask you to take the first cut at this, but it's actually a very broad question that I hope others will weigh in. A number of people have mentioned with the new administration coming in that there's climate is a focus. But as we heard in the introduction, the ties between climate and health haven't been the focus of most discussion about climate policy. Similarly, based on your work, food policy or school lunch policy has been mostly tied to nutritional value. And as you said, with schools closed, clearly feeding kids is the top priority, but hasn't so much been tied to climate and environmental health. How do we start bridging some of these gaps? Maybe you could start with bridging the gap between food and climate, and others could talk a little bit more about bridging the gap between other aspects of health and climate.
Yeah, I think that's one of the reasons I was interested in taking on this study is coming from a nutrition background. Dietary guidance often usually hasn't considered the environmental impacts of food choices. So I think that's the really unique part about the Eat Lancet Commission's work, is it's really the first set of guidance to look at both of those things. I think there's a lot of opportunity in working with local schools to have conversations about their current practices related to things that impact the environment, particularly leveraging the youth voice, as I mentioned in the presentation, I think is a really interesting point. I also think the role of food policy councils in cities and states really present an opportunity to have a lot of cross-sector collaboration between nutrition and agriculture and environmental experts. So I think that could be one meaningful way to have these dialogues and think creatively about policies and programs moving forward that unite nutrition and environmental health.
That's great. Paul and then Chris. Paul?
Yeah, thank you. And I wanted to mention also that CDC has a guide on cross-sector collaboration on climate and health, and it's written for health departments. So it's really how health departments can collaborate with 10 different sectors, ranging from agriculture to energy and utilities, the healthcare sector, urban planning, wildland management. I mean, it's pretty broad, but I think it's also useful the other way around. You know, if you're in a sustainability office or a company that works on transportation planning, why would you want to collaborate with health on issues of climate and health? So I think that's a good a resource for this topic, and I'd be happy to share that.
Thank you. Chris.
Thank you, Paul. And I can say this and Paul can't. Paul does just remarkable work with an absolutely minuscule budget. And a lot of this comes down to just financial investment. When you look at the National Institute of Health, their total budget around climate change and health is about 0.04% of the budget. It's not a serious issue at NIH. The National Academy of Medicine, for the first time, has taken on climate change as an issue. So when you think about the science policy interface, the science is massively underfunded. I know we always say that, but the scale at which this is massively underfunded is just hard to imagine. And then how do you have a science policy interface when you don't have people seriously taking this up at the agencies that are supposed to be bringing this forward? And that is both at the state and at the national scale. As I said, Paul and CDC are really to congratulated for what they've been able to achieve with a very small amount of money. And I'll speak just for my state of Washington that would love to be involved in the program that Paul has, but they don't have enough money. And I know other states as well that keep saying, is there a way for us to get into this program? It's such a good program. But just the investments aren't there, the political wills aren't there, the interest isn't there from the people who need to fund this.
Other reactions on this topic? Paul, since you jumped in, we did get a question about the BRACE framework and whether it might be applied more broadly. And maybe you could say, I know you introduced it, but maybe you could say a few more words about it and what it would mean to apply it more broadly.
Sure. So for those who aren't familiar with the BRACE framework, just very briefly, it's building resilience against climate effects. And it's our framework that we developed almost a decade ago now that health departments used. There are a few organizations other than health departments that use it, but it's primarily for health departments. And it's a 5-step process where they look at their local impacts, develop a climate adaptation plan from that to protect health, and then implement and evaluate it. That's kind of the 30-second version of what BRACE is. And it is designed to be a flexible framework. So we've had everyone from a state, local, tribal, territorial health department implement either all of BRACE or parts of it. But we've also seen universities do it and other government agencies that are not health. So for example, a mayor's office of sustainability. There are a few examples where people have adapted it for their own use pretty heavily. And one example is actually covered in this Journal of Health Affairs. It's what the Swinomish tribe did. And they developed a series of indigenized health indicators because what we described as health in the BRACE framework didn't work for their situation. So they took their local data and changed up their indicators that they were using to measure health. And they've actually released a couple of public modules on that so that other tribes can then look at how they can adapt BRACE for their situation. And one other quick example I'll mention is NACCHO, the National Association of County and City Health Officials, created a document that looks at how small, unfunded, or slightly funded jurisdictions can implement BRACE. So, if you don't have the full funding that we give out to states, for example, you can still do it. You'll be limited, but they gave some good tips on how, say, a smaller city can implement the BRACE framework. If you're a jurisdiction or someplace that doesn't have funding for it, all of the guidance that we've created for it is publicly available.
Great. James, you want to jump in?
And so I also wanted to just make one point, which really I think crosscuts with Paul's comments on this sort of multi-sectoral approach. But this has been certainly the year where COVID has been overlaid on everything. So I think increasingly we have to be considering these superimposed disaster situations. As one example, we've been talking a lot about climate-driven hurricanes in this hyperactive, record-setting 30-storm season. But then at the same time, we had COVID. So at the health department level, for example, and at the county emergency management level, they had to prepare for the impact of hurricanes when COVID was actively spreading, particularly along the hurricane coast. So this is a situation where we have to be thinking bigger and also drawing in from different disciplines on certainly a population level to be able to deal with both the physical and the ultimately mental health effects of climate-driven storms or other disasters, as well as these complicating factors like infectious diseases. This will not be the only pandemic this century, certainly.
Well, you foreshadow what was going to be my final question, which is policy change is always hard, but as a country, we're coming to grips with the notion that there's going to have to be some re-engineering of many systems in the wake of COVID. If you could suggest one thing to policymakers that would improve climate and climate effects on health that could be somehow tied into a COVID response package, what might you propose? And we'll take this as the last question. Here's your chance to be policymaker for 30 seconds. Someone has.
If I was a policymaker for 30 seconds, I certainly would make some structural changes in our agencies that focus on health issues and ensuring that climate change is mainstreamed across, that the kind of work that Paul's doing at CDC reaches across all the programs at CDC, reaches into all the states, not just some of them. And thinking, for example, there was a Scientific American article published by Professor Frumkin and Jackson that proposed a National Institute for Climate Change and Health. It's one way to approach ensuring that this is taken up as a serious situation, but basically a change that would ensure there is the political will and the mandate to be able to ensure that our national and our state agencies protect and promote human health as the climate continues to change, and to not leave individuals and communities behind.
Jodi.
Well, just to reiterate, we certainly don't have the luxury of addressing one crisis at a time. There are a lot of synergistic problems and solutions between COVID and climate change and the response of the healthcare sector. I want to reiterate that there could be no more important policy from my perspective than mandated emissions reporting and accountability through the Centers for Medicare and Medicaid. I'll use this opportunity to say that one of the things we've seen from the COVID crisis is that our over-reliance on single-use disposable medical devices, one of the largest contributors to health sector emissions is medical devices, that our overdependence on these single-use disposable devices has left us vulnerable to shortages. And so one of the solutions includes moving back toward more durable equipment. And this will not only help reduce emissions, but improve our resiliency at the same time.
That's great. Well, I think, Shasta, you'll get the last word.
Thank you. As far as COVID and climate change and the way they overlap, we can see from the disparate impact of COVID on Native American communities, in particular the Navajo or the Diné Nation, that there's health disparities there that go way back to before COVID. And so that's something else, not just in tribal communities, but in general, that we need to make healthcare more accessible and less expensive. And I mean, I'll just go with my liberal point of view, which is it just needs to be available for everybody without worrying about how they're going to pay for it. And I think that by itself will give people the freedom to be able to think about some of their other behaviors in terms of their own personal impact on the climate crisis.
Well, I am so grateful to all of you for your contributions today. Thankful for the support from the Robert Johnson Foundation and the Kristie Foundation for this issue and the briefing. Kristie Ebi, thank you for your leadership on the issue. I do want to remind our audience that we could only touch on a small number of the papers in this session today, and you'll find a lot more depth and many other topics addressed in the December issue of Health Affairs. So if you found this a good start, I hope you'll go even deeper within the issue. With that, many thanks to you all for your time, for your papers, for your wisdom today. And we are so pleased to have this first issue. It makes me ready to have a second one, but let's make some good things happen between now and then so that we can show the impact that good scholarship and research can have on health and healthcare. And with that, we are adjourned.